Hello, welcome to EM Offsides. Today I'm here with my guest, Dr. Matthew Butler.
Hello.
You can tell us a little bit about yourself?
So I'm a podiatrist in Boston, Massachusetts. I have three offices. One is in Middleton, Mass, which is just north of the city. I work closely with a family practice there. Another one is west of the city in Marlborough, Mass, which is more like a smaller office to see residents, people out there. And then I work out of a hospital, the Brigham and Women's, but I work out of one of their satellite hospitals, the Faulkner, and I'm there every other Friday. So my day, I could be anywhere from the hospital to a clinic to my private office.
Well, that's
And
awesome.
yeah, been doing it for about 27 years now.
Okay, great. So today we wanted to talk about ingrown toenails, something that in the emergency department or in urgent cares we see. I understand the gist of it, but we've never been formally really taught about how to deal with these, how to manage them. So I was hoping you could give me some insight in what we should be thinking about.
Typically an ingrown nail is where the nail itself on either side of the toenail, the medial or lateral aspect of the nail border is quote unquote digging into the nail tissue where it's causing discomfort. And typically they have a history of it, or they may have a genetic history. They know their father, mother, brother, sister might have gotten it, but they know that it hurts, it's sore. They may have tried to take it out themselves, but they'll come in to see me for further treatment because they've been unsuccessful.
And is this can be any toe? I've generally seen it in the first toe, but it could be any of them.
Correct. I've seen people, that's the most common, either of the big toes, but I've seen people in the second toe or the third toe, sometimes the fifth toe. It could be due to trauma. It could be due to tight shoe gear. It could be due to if they have like a fungus infection in the nail, or the nail's a little, we call it dystrophic in those lesser toes where it's getting compressed because it's, especially the ones in the middle, the second, third, and fourth, they're getting compressed. And over time that nail can dig in.
So basically it's when the nail is sort of curving in on the sides, digging into the skin on the side of the nail bed there. So how do you officially make that diagnosis? Is this, you can just look at this and see this is an ingrown toenail? Because in my experience, some people have nails that seem to be poking in, but it doesn't bother them. And then some people have it and it's bothering them.
Correct. So my history is key in the beginning. If they say to me, well, I was doing bathroom surgery and I usually do this all the time, where it starts to curve in and starts to hurt, and they might try to dig it out. There I'm already thinking, okay, maybe they've taken too much of it out. Or if I'm looking at their nails and I see that they like to keep them super short, a lot of times that can create it. So in the history, I'm assessing that. Or did they drop something on it? I stubbed my toe really bad, and after a week later, it's been sore and it's just gotten worse. Or I'll even look at their shoe gear. If there's somebody that wears tightest shoes, or soccer players, anything with that or women in dress shoes, that kind of leads me to believe, okay, before I even take the shoe off or look at the toe, I already know that there's a possibility of an ingrown.
And then once you look at it, what are you looking for?
So the typical ingrown nail will have some sort of swelling next to the either border, or where I'll ask them where it hurts. And you could pretty much, as soon as you look at it clinically, either medial or laterally, you'll see where the complaint is. And a lot of times I've had them on both, but there'll be an increase in redness, an increase in swelling. You might see some drainage coming from the nail, obviously tenderness when you palpate it. And it can be any degree from nothing at all, but it just hurts, to it's severely painful, and also severely swollen, severely, draining quite a bit. The one thing I wanted to mention, there's also this very characteristic, a granuloma will form on the edge of the nail. Sometimes you'll see that. It's like a red, beefy ball of tissue. And that's obviously an indication to me that they've had it for a while, because they've had so much pressure there and tension and bleeding that a granuloma had formed. So those are my key things.
And generally, if you were to press on that side of the nail, it should be tender for them.
Correct. Exactly. Now, if they're neuropathic and they just know any better, or they're diabetic, a lot of times they may not feel it. But I've had patients with neuropathy that the level has gotten that much, or there's possibly even a pocket of pus in there that can create that. So yes, that's the most common presentation.
So let's say we've got through the history, we've got through the physical, and we're pretty certain we're looking at an ingrown toenail. What are the different stages of an ingrown toenail, and how do we tell which stage it's in, and what do we do about those different stages?
Okay, so something that's mild will show maybe a little bit of redness, a little bit of tenderness, and a little bit of edema. In those particular circumstances, what I would do was give them soaking instructions and put them, if they are possibly a diabetic, immunocompromised, or have had a history of ingrown nails, or depending how long they've had this, I would put them on a broad spectrum antibiotic.
And for the soaks, you're talking about maybe 15 minutes once or twice a day, or?
Correct. Lukewarm water, little table salt. If they don't have Epsom salt, it's fine. Make sure that it's salinic, and basically treat it that way. If there's drainage, use gets a pack of non-sterile gauze, put a little piece with a little bit of antibiotic ointment on it. I wouldn't have them burying it in that, because that can create maceration. So just a little bit, and then follow up with a podiatrist in less than a week or so. You know, if this is something that's moderately sore, you know that this thing is not going to get any better. You know that it's, like I said, it has that incurvated edge that you palpate it. It's really sore. I would grab some, in my office, I use Marcaine, but you can do, if you have lidocaine, it's fine. The other thing I like, and I don't know if you carry them, is the cold spray cans. I like a little spray of cold spray to numb the toe, because patients are very anxious about this to begin with and getting numbed up. And all these little steps that I'm telling you help with numbing of the toe and alleviating a lot of their stress. But I would do a digital block on that region, whether it's medial or lateral, and I would do a partial excision and remove that offending nail spicule and let it drain, because something that's on the moderate side to severe side is not going to get any better without removing that. It's only going to get worse.
And then those patients, you're still going to discharge on Caflex, antibiotics, do the soaks, and potentially put a little bacitracin on a gauze and have them wrap it.
Correct. Don't let them overwrap it either. You want this, the first dressing, obviously, because it's going to be draining and it's going to be bloody. The first dressing you put on, I like Coban. A lot of ERs will have that. A lot of offices will have it. Coban is nice and constrictive. You put it on, and I tell them that night to do their first soak. Take everything off and do their first soak. Don't leave it for the next day. Take it off, and then when they dress it thereafter, like you said, with the gauze, I like paper tape, especially with patients if they have allergies to adhesives, and adhesives can be kind of constrictive. A little bit of piece of paper tape, lightly bandage it, because over the coming days, again, our goal is to dry this region up. So the soaks are going to help dry it up. And probably by the 5th day or so, as there's less drainage, I'll tell people, if you're home, you're relaxing, remove the dressing, let it aerate, let some air get to it to help encourage an eschar to form, or just to dry the region up, which will help with overall infection.
Yeah, maybe walk me through that excision. So let's say we know how to do those digital blocks. So we'll block up the toe. And then what's your approach there? Like, is it sort of, I mean, if you're looking at the nail sort of like this, are you taking like a pizza wedge slice out, or
correct?
How up are you going?
Correct. That's a good question, because if you're looking at the nail, let's say it's only a third of the nail that is that part that kind of bends and curves. That's where I'm going to begin how far in I'm going to come from the nail border in to make the excision. Definitely do not take a small amount. I'm not afraid to take a good amount of the nail out. I'm not saying the entire half of the nail, but a third at least over, especially if it's curving. If any medical practice, and I know in the ER they don't have them, but if you had like an English anvil is a great instrument, but something that would, I've even seen in a pinch, doctors use bone cutters, just something that has that plier effect to cut the nail. If you only have scissors, as long as that nail's, like I was speaking of earlier, if it's a thick nail, you're going to have a hard time cutting through that with a scissor. But in the event, if you can get something that will cut the nail, if you're lucky enough, take a good part of that portion of the nail and make sure that they're aiming straight back.
You're going all the way up to the cuticle and getting the entire nail from under the nail bed and everything, just pull it
exactly. So as you're going back, you're going to feel there's going to be some resistance. And as you go underneath the nail matrix, which underneath the nail tissue, don't be afraid. Just make sure you angle it. You don't have to cut into the skin. You can kind of angle that underneath and go in, and you'll, just as you go beyond that, you're going to have some resistance, and then it's going to give. And then as you go a little further, and you'll feel that the harder portion of that nail matrix is, you've surpassed it. You cut it down. You guys can use those forceps, the other end of it, to loosen up the nail. You know how not the end of, not the distal piece, but the proximal part of the nail forcep.
Okay.
You can put that underneath the nail now that they're numb, and you can use that to tease up the nail a little bit to loosen the nail. That'll make it much easier to cut it. And you want to free it a little bit from the nail bed itself. So make sure you do that, and then kind of take it back as far as you can, all the way. If you can get all the way back to the matrix, great. If you can't, take it as far as it can, and then loosen it on the medial or lateral aspect as well. That way, if you do take a scissor or an instrument and cut, it'll be much easier now that it's been loosened underneath. And then, like I said, go straight back. Grab your hemostat, take the hemostat and grab onto the nail itself. And then if it's on the lateral aspect or the medial, you're going to go out towards you're going to be almost like a pulling back, but also twisting it up.
Like a rocking motion. Okay.
Correct. So you're pulling it out, and that piece that's growing in flops up as you're pulling it. And you don't have to yank it, just a nice steady pull, and you'll see the nail will start to come out along with all the remnants of the matrix that are attached to it.
Okay. And you're giving them about a week of antibiotics, or?
Yeah, I like if you know that they're going to follow up with if just having them follow up with a medical specialist, I'd give them 7 days, 7 to 10 days. If it's mild, I'd give them 7. If it's moderate, I'd give them 10, just to cover our bases. Okay. And then if you guys are lucky enough to get you can grab a culture, there's something to culture. You know, that's the other thing we didn't speak of. Once that nail's removed, if you want to go in there and take a culture of it, an aerobic culture, and send it off, that'll kind of give you a better idea. Pretty much we know what's in there, but that is covered by a broad spectrum. But every once in a while you can get something that's not. But if you don't culture it, at least what they're doing is great. The other thing I was going to mention is if it's mild to severe, they're diabetic, or they've had it for a long time, I put people on Augmentin. I love it. I give them 875 twice a day. That's my hammer. And I'll give them that for 7 to 10 days, because if God knows what's going on in there, it could be there could be other bugs, and I want them covered, and I want to really knock this thing down. So I've learned that in my residency, and in my, the docs there love that. They were using Unison, if anybody remembers that. And on the oral, it was Augmentin, and Augmentin was a great polymicrobial drug.
Okay. So that's for your diabetic, immunocompromised patients. But
Or
your
somebody
average patient with a moderate to severe, you're going to give them Keflex probably. And then for people with very mild, you may not even, and with no risk factors, you may not even do any oral antibiotics. You may do the soaks.
Correct.
Possibly a little bacitracin.
Correct. And just to kind of clarify too, if you see somebody, they're young, and maybe they're not a diabetic, but it looks severe, I would hit them with Augmentin, because typically by just removing that nail spicule, it's going to be dramatic. Like their whole, everything's going to clear out, and they should be great in 2 to 3 days. But if I'm kind of like concerned, I might, if it's a really wicked infection, pretty nasty, I would definitely put them on Augmentin for 7 days, just to clear this thing up. In those particular cases where it's above, where maybe Keflex, I want to do something a little stronger.
Okay, we know to do the soaks, the antibiotics, we may have excised the toenail, it may grow back. But what about when patients ask, like, why is this happening to me? How do I prevent this from happening to me?
Correct. So education on how to cut the nail properly is number one.
So what you're mentioning is, can you explain that one more time? Like,
sure.
How should someone cut their nail?
I say cut it as it grows. Don't cut it at an angle, meaning, so like if you see the white piece of the nail, just cut the white piece of the nail coming across. So if it's a straight nail, you're going to cut it straight across. If it's curving, you're going to cut it and tilt the nail nipper and cut down into it. You're not going to angle it back.
Don't cut back.
Correct.
Okay.
Do not do that. That's the best way to get an ingrown nail. So the other thing, just to mention, because you might have patients come in and say, "Oh yeah, I learned this trick where you cut like the toe at an angle, and somehow it corrects ingrowns." Like there's I'm trying to think of what they
I
call
mean,
that.
you would think that that would work, right? You would think, oh, let me
Correct.
get rid of this part that's bending down.
Correct. If I cut it in the center in a certain way, it'll grow inward and not grow incurvated. But that's so I've never learned that in school. And people come in and ask, and they said, I've tried that. And I said, that's great, but that won't correct it. Cutting your nail, letting it, I'm not saying growing it too long, but don't cut it too short. Number one, cut it straight across as it grows. Don't cut it at an angle.
Okay.
Tight shoe gear is huge. Make sure that if they say, well, I like how this style of shoe is. Well, if you do, then you need to change out your shoes or pay attention to your toes. And obviously, as they're growing out, and then making sure that you have enough room in your toe box so that you're not getting ingrown, because that's another way that people get it. If they have like a fungus infection in their nail, or prior trauma, that can cause an ingrown nail because it's a thicker tissue. The body, it's like not pliable. So the body thinks, oh, this is like a foreign body. So as it grows out, a little compression from the shoe can cause pain, infection, what have you. So they can get the fungus treated. That's another way to go about preventing ingrown nails. But the most common, tight shoe gear, the way they cut it, or like I'll have a lot of 16-year-old kids that will come in, or their hygiene's not the best and their nails are extremely long. Those guys are the ones also that are they're wearing Chuck Taylor sneakers, they're snug. They're getting ingrowns because they're not trimming them at all. They're just letting them grow as long as possible. And then that's the other side of it. So common sense, cut it as it needs to, but don't overtreat it and don't undertreat it. So
that's great. I mean, you really walked through this from A to Z in a way that I feel like I feel pretty good about it.
Awesome.
Is there anything that you're thinking we should talk about?
I'm thinking, yeah, because there was one other thing I was going to bring up, but I think that's the most important thing is educate your patients when they start to get these things that pick up a pair of nail nippers. It's the easiest thing to do now on the internet, because using a pair of nail nippers, they'll cut their nails more efficiently. Make sure that you're checking your patients and talking about their shoe gear. I've had so many people come in that don't even realize that a tight shoe can create enough tension on the toe to create an ingrown. And if they start to get an ingrown, don't treat it themselves. Come in to see you, or when they do see you, refer them to a podiatrist. And like we said, the last thing from a medical professional standpoint, again, I don't know anything about it, but don't use silver nitrate on granulomas. Don't cauterize a nail. That you're creating more trauma. Put them on an antibiotic, give them basic soaking instructions, and do what you can. If it needs to be trimmed, trim it. If it can stay, refer them to a podiatrist at some point for follow-up.
Gotcha. Well, thank you so much. This was super informative.
I enjoyed it. Anytime you'd like to chat about anything foot, I'm your guy.
All right. That sounds good.
Thank you for having me.
Yes. Thank you, Dr. Butler.